Hi, my name is Dr. Andrew Lerman. I'm a neurologist in the Coral Gables and South Miami area. We are going to talk about a couple things today, one of which is definitely, which we're getting a lot of questions about, coronavirus and neurological disease and what some neurological manifestations of this illness could present as well as the use of telehealth, teleneurology services for management of neurological illness in this time frame during this community health crisis. We're going to let a couple people roll in, and then we'll be answering questions live here on Facebook regarding these two topics.
We'll just wait. Let's let it link into.
We're just letting a couple people log in. Hope you're all having a great Wednesday. So, one question just came in regarding coronavirus and characterized neurological components. The good news is that based on experience with some of the other coronavirus variants, SARS and MERS, that we've seen previously, there seems to be some neurological sequelae, mainly periviral kind of complaints, but neurological complaints have not been a major focus of these illnesses, and thus far we really have a lot of discussion regarding COVID-19 neurological syndromes or sequelae of this infection. However, it's still quite early, and we are starting to see some data coming from China and some anecdotal reports of clinical evidence or data coming from extracted electronic healthcare records, which have been reviewed, and they fall really into three categories: central nervous system complaints such as headaches, dizziness, impaired consciousness, or encephalopathies associated with viral syndromes, ataxia or dizziness associated. We are seeing some degree of acute cerebrovascular events and disease, as well as seizure disorder. In the peripheral nervous system realm, we are seeing some complaints, and in the social media and media, some people are reporting difficulty with sense of smell, so hypoosmia, hypogeusia, which is a change in taste, and some degree of tingling or paresthesias associated, and then there's skeletal muscular complaints that we're seeing as well, mainly myalgias, which are typical in viral syndromes. In a paper recently published on 214 patients coming out of China, there are really neurological complaints seen in patients with severe illness. A lot of them had headache, dizziness, and to some degree confusional state or encephalopathies. In my practice thus far, in seeing patients in the hospital, this is consistent. A lot of patients are reporting muscle aches and pains, again, typical to all viral kind of illnesses, and not necessarily specific to coronavirus. But if you are starting to experience, high fevers, muscle pain, aches, changes in taste or smell, these could be early signs of illness, and you may want to notify your medical doctor or get tested or come to one of our testing centers. Another question here is, can you elaborate on the specific neurological complications that may occur with COVID-19? So other than what was just mentioned in terms of headache, dizziness, and kind of generalized muscle aches, there are reports of acute disseminated encephalitis, brainstem encephalitis. There are reports, but not quite established yet, of potential for Guillain-Barré syndrome. I personally have not seen these in my community as of yet, but we are keeping an eye out and in evaluating all patients with COVID-19, definitely keeping an open mind as to what are the potential repercussions from a neurological perspective, and extrapolating to future care and patient care in the hospitals and in our office. Do I have any advice for neurologists out there on how to address the pandemic? As I just said, I think neurologists should be open-minded. If they're asked to see a case, you should certainly take caution and care as delineated by the CDC and each hospital policy, but definitely keep an open mind about what could be a potential neurological symptom of this illness, learn from it and extrapolate and help to help other providers and help guide management. Also, it's important to keep up to date on the latest data that's being published. Definitely stay in tune with our neurological news, which has been great thus far in helping us, and definitely counseling patients on who may be at highest risk. Patients with Parkinson's disease, ALS, multiple sclerosis, myasthenia gravis. All of these patients are considered high-risk patients and should be counseled accordingly and should be given guidelines as to how to protect themselves maximally. I'm going to move on to discussion of telehealth and neurology and how we've really been able to continue management of patients previous to this crisis and continue to provide the best care possible. So for many neurologists, telemedicine is uncharted territory. However, in the COVID-19 pandemic, we've really been prompted to explore ongoing treatment as well as new consultations for stroke, epilepsy, Parkinson's, dementia, and other subspecialties within the neurological realm, and really trying to pivot into the new era of online consultations. In the interest of patient safety, in the interest of physician safety, we've really had to shift quickly lately. In my practice, we've been providing teleneurology services for several years. However, lately we have really encouraged most of our patients to try to enroll and try to pursue this, again, to protect them, most importantly, to protect our staff and to protect ourselves as healthcare providers, because we would like to stay healthy and continue to provide ongoing care to our patients without hiccups. So one bright spot or one positive thing that may come out of this corona crisis, and we're always trying to look for the silver lining right now because there's so many negative things in the news that incite fear in us and panic, is that our healthcare system is transforming, and it's already been transforming, but this has pushed us to really promote telehealth services to be used more widely. And I think that is going to have a great impact on how we deliver ongoing healthcare, both from an access perspective, from a healthcare cost perspective as well. So as of early March 2020, Congress passed legislation to allow the Department of Human Health Services to waive certain requirements that providers could really expand their use of telehealth services to all patients, Medicare patients, and really has been a very helpful thing for patients in general. As a neurologist, I'm proud to say that the American Academy of Neurology has been advocating for this for so many years, and that now we're able to really get things going, and hopefully we'll continue with this momentum moving forward. Again, I've been personally using telehealth for many years, and we've been trying to mitigate some of the hurdles that that have come up in terms of how it takes some creativity sometimes, and we continue to optimize comes from this perspective. So now that in our practice we've been using an electronic health system that does have built-in teleneurology or telehealth services, but things that have emerged recently like Zoom, Doxy.me, video, all of these have really been effective platforms that have tried to optimize ease of use for patients and physicians alike to allow for us to offer this service. As a community epileptologist, I find that this medium of providing care is optimal and adequate for follow-up management of seizure disorders, of various conditions such as migraine, dementia, some movement disorders as well as chronic pain. I've always been sensitive to the cost of our healthcare system in terms of transportation burden, as well as burden of caretakers regarding follow-up appointments and the amount of time it takes for some of my patients who are wheelchair bound, not able to get out of the home very easily, and it seems like you're parting the steed to get them in to see their doctor, and now they can just be seen and receive the same type of care in the comfort of their home in order to present for a 20-minute, 40-minute visit. They can really save time and effort and money. Dementia patients and their families have been quite pleased with follow-up appointments. They're able to sit in as family members from different parts of the country could all come together to hear about what's going on with their family member, as well as give some input about what they see, which I find has been a remarkable advantage in care of dementia patients, and has helped guide management and outcome as well. Again, epilepsy patients, we've teamed up with the Epilepsy Foundation of Florida. We helped to obtain a grant that has given epilepsy patients access to telehealth for the last 2 years, and has been a remarkable program as most of these patients can't drive because of their underlying illness, and really we can do 99% of what we need to accomplish via video chat. Migraine patients, a lot of my follow-up migraine patients present via teleneurology. We discuss their symptoms, we discuss potential triggers, we review their migraine journal together. We have the capacity in the office as well to review imaging, which has been quite effective for follow-up visits. I do sometimes need to perform certain things in the office, like fundoscopic examinations, For certain types of other illnesses, we need to do more complex neurological testing. But for the most part, follow-ups with migraine, sleep disorders, pain, we can pretty much do over the video. And we've come up with interesting and creative ways of performing this exam on your smartphone now. There are even apps to do fundoscopic exams for certain types of cases. Motor examination is pretty well tested over the video. Obviously, there may be some limitations there, but for the most part, we can perform that. Reflex, we can at least perform a cursory examination that will help get a work. And if we do need to see the patient in the office, we can. Seeing a expansion of telehealth services into the hospital. For many years, patients have been seen for acute stroke management. This has been going on for at least 6 to 8 years via a telestroke service. However, we're seeing even in our local hospitals now, in order to mitigate exposure to some patients that may be infected with COVID-19 and to try to protect the patients from caretakers spreading the illness and physicians from getting sick, nurses from getting sick. There's been apps created on that patients can download on their phone, and I could log in, perform a visit just like I'm doing right now, and explain MRI results, lab results, what's going on with the patient via this app in order to, again, reduce exposure, but also reduce use of resources such as masks and gowns, which we have seen to be our healthcare system at the present time. We have been seeing a lot of healthcare workers, unfortunately, call out or get sick with COVID or at least need to quarantine. And we're trying to do everything in our power to keep our people on the front line safe right now. And even physicians who have tested positive for the virus but are relatively doing well can remain at home quarantined in a safe environment, but still see patients and help the hospitals to care for and help their practices to continue to care for sick patients that are in need. So I'm very sensitive and well versed on the barriers of use of telemedicine. And I understand that some patients, this route of receiving care may be quite difficult. But for this reason, we've set up a system in our office and continue to optimize where my staff is trained, and we have an extensive staff in the office to help patients utilize and set up easy access. And so I'll spend the rest of this talk discussing that and just giving an idea of what to make it seem as if we're seeing a patient in person. So our staff sends patients for a neuro-tele visit. We help, this is several days in advance. We help test connectivity, and we remain available to evaluate for any technical issues that may arise with their particular setup. And this is done 1 to 4 days in advance of the consultation in the office. At the time of the consultation, we've set up a streamlined approach similar to that you would have when you come to the office, so that the patient experience is similar, and you can really allow for optimal collection of background information and set up a seamless type of visit. We have staff members who check who check, everything that we would normally check on an office visit, such as past medical history. We have them check social history, surgical history, review of systems. We reconcile their medications as we normally would, both with the patient and through the electronic health system, that we can check pharmacies and what they've been receiving. We check e-force as we previously have in the past and conventionally. We discuss any related issues in setting up an electronic prescription capacity. So we check their pharmacy and make sure that all the information is correct. And recently, even controlled substances in my field, we prescribe anti-seizure medicines that are controlled. And recently, the laws surrounding electronic prescription of these medications have been relaxed so that we can effectively make sure that these patients take medicine and receive medicine without a holdup. From a technical perspective, the visit is set up in such a way that we have a private room available. The environment is easy and comfortable for the patients. We make sure that the visibility and the sound are well controlled for, and that all the equipment is set up so that we can show images and show results of previous workup. We are getting better and better and better at this. There's been more and more tools available to us to provide virtual visits that are almost as seamless as a visit in the office. Here's a question. So many people ask about the examination, and again, as I mentioned earlier, vital signs may be limited. Reflexes exam may be limited. Some of the neuromuscular examinations, which require a complex hands-on approach, really could be limited, but for the most part, and vestibular testing is difficult, but for the most part, our mental status exams can be done completely. Many mental status exams can be done nearly completely. We can do cranial nerve exams without difficulty. Motor exam, everything can be assessed, including handwriting, fine motor movements. There's a slight limitation in terms of rigidity and testing some degree of Parkinsonism or Parkinsonian features, but a lot of things can be extrapolated. Gait testing is something that we do on the video, and patients walk and are able to perform Romberg testing and all types of complex gait testing as well. And in terms of the post-exam, post-assessment recommendations, again, as I mentioned earlier, electronic prescribing has really been implemented for quite some time and continues to serve as a tool. We have electronic referral systems, so other physicians can be contacted immediately at the time of consultation for referrals. We can send referrals to physical therapy. We have been really able to now perform electronic prescribing of controlled substances for patients who are requiring that. And so finally, there's a silver lining here. And the silver lining is that we are really trying our best in the medical world to roll with the punches of the healthcare situation. We have had significant interest from patients, both for telehealth, but also a remarkable thing has happened in that patients have really expressed a lot of interest in, doctor, how can I do what I need to do for myself. How can I perform exercises, self-care, physical therapy on my own so that I can get better in this time period and not continue to for the future, as we don't know what's going to happen, really. And so it's been a remarkable thing, and we've really tried to roll with that as well in creating videos, trying to build a database of material that patients can look up or receive electronically for exercises they can do for cervical radicular pain, lumbar spine exercises, physical therapy for gait disturbances, for walking in the setting of peripheral neuropathy. So we're going to continue to change and optimize, and the outpour from patients in terms of their willingness to also change has been remarkable, and we continue to encourage this, and it's really uplifting to see, and we are going to continue to be here for patients. And I have a question right now: do you take Humana managed Medicare? We do, and we take most Medicare providers. You can call the office, and my staff will be happy to answer all those types of questions. So again, in summary, for many years now, my office has been trying to learn the pitfalls and barriers of telehealth services and teleneurology services, and really try to optimize the care that we give, the access that we give to our patient population. And we've been working with the Epilepsy Foundation, we've been working with the Parkinson's Foundation, and community leaders, physical therapists, everybody who really just wants patients to get better and have great access. And now, in the time of crisis and in the time of need, we're here to help, and we'll continue to be here to help. So if we can be of any help to anybody out there, please do not hesitate to reach out. Please be safe. Follow the safety guidelines in terms of protecting yourself from this illness, and please take care of yourself. If there are any, we'll wait a couple minutes for any questions, but really thank you for listening today, and more to come. I think next time, we've been getting a lot of questions about neurology, telehealth, and medical cannabis. So we'll be probably discussing some issues related to that next time. And please stay tuned. All right. Have a great day. And again, be safe.